Welcome to the e-learning module on pathology of nutritional anemia. This session is on macrocytic anemia, which is divided into two sections. So in this, we will be telling about the causes and types of macrocytic anemia. The objectives of these sessions are: what are types of macrocytic anemia? Enumerate the differences between megaloblastic and non-megaloblastic anemia. Describe the etiology and clinical features of megaloblastic anemia. Explain the metabolism of vitamin B12 and the causes of vitamin B12 and folic acid deficiency. So what is macrocytic anemia? So macrocytic, as the name suggests, there is anemia characterized by RBCs which are larger in size. So how do you assess the size of the RBC? RBC size can be assessed based on the peripheral smear examination or by using the RBC indices, in which we will be using MCV as the indicator of cell size. So if you see the peripheral smear, you assess the size of RBC by comparing it with the size of nucleus of the small lymphocyte. So if it is larger than the small lymphocyte nucleus, it is called as macrocytic. Based on the MCV, the normal MCV is 80 to 100 femtoliters. So if it is more than 100 femtoliters, it is considered as macrocytic anemia. So, based on the etiology and bone marrow examination, macrocytic anemia can be classified as megaloblastic and non-megaloblastic anemia. So, to consider whether it is megalo or non-megalo, you have to either examine the bone marrow or you have to do certain biochemical investigation. So, in non-megaloblastic anemia, the peripheral smear will show macrocytes, which are large RBCs, round in shape. So they are round shaped macrocyte. Whereas in megaloblastic, they are oval in shape. So they are called as macroovalocyte. So when you examine the peripheral smear, the size of the erythroid serous precursor, which are erythroblasts, they are larger in size. So they are called as megaloblast. Whereas in non-megaloblastic anemia, the size of these erythroid series precursors are normal in size. So they are called as normoblasts. So the causes differs whether it is non-megaloblastic or megaloblastic. Causes for megaloblastic anemia are vitamin B12 and folic acid deficiency, and it can be treated with supplements. And the causes of non-megaloblastic anemias are liver cell disorder, chronic alcoholism, aplastic anemia, which is a stem cell disorder affecting the bone marrow, or myeloblastic syndrome. So when we examine the bone marrow smears or bone marrow biopsy, as I told, in megaloblastic anemia, they are larger in size. So they are called as megaloblasts. So how do you differentiate whether it is normal or megaloblast? So that is mainly by examining these erythroid precursor cells. So in normal erythroblast, the size of the cell and the nucleus is normal. Whereas in megaloblast, the size of the nucleus is larger. How do you say that they are larger? So as they mature in stepwise manner, as it is already covered in the beginning, so the nucleus should undergo condensation. But that condensation doesn't happen in megaloblastic anemia because of there is some defect in the nuclear maturation. So the maturation of the nucleus will lags behind the cytoplasmic maturation, causing open chromatin, open pale chromatin. So the nuclear chromatin will be lighter or pale in megaloblastic anemia. That is why the size of the cell is larger compared to a normal erythroblast. So as you can see in this picture, this is a normal erythroblast, this is a megaloblast in the same stage of maturation. So you can see it is a very big erythroblast, which is megaloblast. So, and you see if you see the nuclear chromatin here, it is open sieve-like chromatin and it is pale in color compared to the normoblast. So there is no nuclear maturation taking place. So with each series in the erythroid series maturation, the nuclear condensation doesn't happen as it is required. So that is why the cell size is increased, but the cytoplasmic maturation remains the same in each stage, whether it is normoblastic or megaloblastic maturation, because cytoplasmic maturation requires iron. So the causes of megaloblastic anemia are vitamin B12 or folic acid deficiency. So what exactly happens in megaloblastic anemia? So main defect is defect in the DNA synthesis. There is decreased maturation of DNA leading to nuclear immaturity. So that is leading to less cell division, causing increase in the cell size, leading to increase in the cell size, that is macrocytosis. So why this will lead to anemia? So these megaloblasts are considered as abnormal. They undergo destruction in the bone marrow, which is called as ineffective erythropoiesis. This is leading to decreased RBC count. But in addition to RBC, all cell lines in the bone marrow or in our body is affected because DNA maturation requires vitamin B12 in any cell in our body. So this will lead to reduction in all cell lines in the bone marrow, which is called as pancytopenia, which characterized by reduction in the RBC count, platelet count, and also WBC count. In addition to folic acid deficiency, vitamin B12 deficiency also causes demyelination, causing neuropathy. So because of demyelination in the peripheral nerves and in the spinal cord. So coming to metabolism of vitamin B12. So the sources of vitamin B12 are mainly animal protein. That is, for the source of animal protein can be kidney, liver, heart, muscle, meat, or fish, egg, and milk products. So, but cooking has very little effect on vitamin B12. That means it is not easily destroyed by cooking process. The absorption takes place in the ileum. So coming to the absorption. So in our food, vitamin B12 is bound to some unknown protein. So when we chew with the food, the salivary protein, which is called as haptocorrin, will be mixed with the blood when we chew with the salivary protein. So this vitamin B12, which is bound to unknown protein, will mix with the haptocorrin, enter the stomach. So what happens in the stomach? There is pepsin, which is secreted by the gastric parietal cell, that will release this bound protein from the vitamin B12. So in the stomach, this freely released vitamin B12 will bind to haptocorrin, that will form a complex, haptocorrin vitamin B12 complex, that will enter the duodenum. So in the duodenum, there are pancreatic proteases which will release the haptocorrin from vitamin B12. So this vitamin B12 will go to ileum. In the ileum, this will bind to the intrinsic factor. So this intrinsic factor is actually synthesized in the stomach, but binding will take place in the ileum. So what happens in the ileum? The vitamin B12, which is bound to intrinsic factor, will be absorbed through the ileal enterocyte. So the receptor required for this process is tubulin, which is there in the ileum. So once it is absorbed, it will enter the blood, binding to transcobalamine, which is a transport form of vitamin B12. So coming to normal folate metabolism, the sources of folate is mainly green leafy vegetables, fruits, or liver. So folate is easily destroyed by boiling or heating food, whereas vitamin B12 is not destroyed by cooking. So absorption takes place in proximal jejunum, and in the intestinal epithelial cell, the monoglutamate which is absorbed will be converting into methyl tetrahydrofolate, which is also a transport form of folate. So once it is absorbed, the excess folic acid will be stored in the liver. So in liver, it is also stored as methyl tetrahydrofolate. So what is the role of vitamin B12 and folic acid deficiency, or role of these vitamins in DNA synthesis? Why it causes megaloblastic anemia? So this is because of the role of folic acid and vitamin B12 in DNA synthesis. So for conversion of uridine monophosphate into thymidine monophosphate, there is requirement of the coenzyme which requires tetrahydrofolate. So the thymidine synthesis, which is which is an enzyme which requires coenzyme methylene tetrahydrofolate. So what is the source of this methylene tetrahydrofolate? For production of this, there is a requirement of the process of conversion of homocysteine into methionine. So when there is conversion of homocysteine to methionine, with the help of methionine synthase, there is methylcobalamin which is converting into cobalamin. So there has to be continuous process of conversion of methylcobalamin into cobalamin and conversion of cobalamin into back into methylcobalamin. So this requires tetrahydrofolate. So in this process, the methyl tetrahydrofolate will be converted into tetrahydrofolate. That will be the source of methylene tetrahydrofolate for DNA synthesis. So what happens whenever there is vitamin B12 deficiency? There is no conversion of homocysteine to methionine. So there is no conversion of methylcobalamin into cobalamin, ultimately leading to trapping of folic acid as methyl tetrahydrofolate. So that is why actually the folic acid deficiency, which is the source of megaloblastic anemia rather than vitamin B12 as such. So the second reaction is vitamin B12 in role in synthesis of the myelin, which is a protective layer in the peripheral nerve or spinal cord. For production of the myelin, we require a process of conversion of methyl malonyl CoA into succinyl CoA. So that requires vitamin B12. So whenever there is vitamin B12 deficiency, there is accumulation of this methyl malonyl CoA. So that will be incorporated into neuronal lipid. So that causes myelin breakdown, leading to neurologic complication which is associated with vitamin B12. So there is no neurologic deficit associated with folic acid deficiency. So this is only seen in vitamin B12 deficiency. So this methyl malonyl acid will be increased in serum whenever we do serum investigation. So what are the salient features of vitamin B12 and folic acid metabolism? Vitamin B12, the sources are animal protein mainly or milk product. And the cooking has very little effect on vitamin B12. Whereas folic acid main source are green leafy vegetables and it is easily destroyed by cooking process. So the site of absorption for vitamin B12 is ileum and for folate is duodenum and jejunum. So coming to causes of megaloblastic anemia by vitamin B12 deficiency. So it can be caused by either inadequate dietary intake, mainly which is seen in strict vegetarian as the source is mainly meat product, or it can be malabsorption. So malabsorption is the more common causes of vitamin B12 deficiency. So in malabsorption, it can be either gastric cause because intrinsic factor which is synthesized by the stomach is required for absorption of the vitamin B12, or it can be intestinal cause because it is absorbed in the ileum. So in gastric cause, the important cause is pernicious anemia, which is autoimmune disease affecting the stomach, or it can be because of gastrectomy. In intestinal cause, it can be malabsorption syndrome like tropical sprue, or it can be Crohn's disease affecting the ileum, or the parasitic infection like tapeworm. So what is pernicious anemia, which is a specific cause for vitamin B12 deficiency? So here it is associated with autoimmune gastritis, which will impair the production of intrinsic factor. So there is vitamin B12 deficiency, which also causes gastric atrophy. So what exactly happens here? There is autoreactive T cells, which causes injury to the gastric mucosal cell, which also triggers formation of the autoantibodies. So there is autoimmune attack on the gastric mucosa. So when you examine the gastric biopsy, there will be loss of parietal cells because they are getting destroyed, and there is prominent infiltrates of lymphocytes and plasma cells, and mucosal cells in the stomach also show megaloblastic changes because of lack of DNA maturation. So pernicious anemia, there is atrophy of the gastric mucosa leading to decrease or absence of intrinsic factor deficiency causing vitamin B12 deficiency. Whereas the causes of folic acid deficiency can be inadequate dietary intake or malabsorption, excess demand, or some other causes like drug intake. So inadequate dietary intake is the main cause of folic acid deficiency. So that happens in teenagers, infants, or in alcoholics. So malabsorption can be affecting the duodenum or jejunum like celiac disease or tropical sprue. So excess demand, it can be physiological or pathological. Physiological excess demand happens in the pregnancy, lactation, infancy, and during growth spurt, during adolescent age group. Pathological can be because of certain malignancy or because of some chronic inflammatory disorders. So impaired metabolism, that comes under other causes. This is caused by certain drugs like methotrexate, which inhibits that dihydrofolate reductase. So what are the clinical features of megaloblastic anemia? So they can present with angular stomatitis, red beefy tongue. So this is red beefy tongue. And peculiar feature is knuckle hyperpigmentation. So that is characterized by hyperpigmentation of the knuckles. That is accentuation of the pigmentation in the interphalangeal joints and terminal phalanges. So the reason for this is hyperhomocystinemia, because of increased availability of the cysteine, because of that conversion of methionine into homocysteine, metabolism is altered. There is increased homocysteine causing increased melanin synthesis, causing hyperpigmentation. So this is the figure showing this is a normal spinal cord. This is a abnormal spinal cord in case of megaloblastic anemia caused by vitamin B12 deficiency. So here you can see excess demyelination in the spinal cord compared to the normal spinal cord. So to summarize, macrocytic anemia is characterized by increase in the size of the RBC, and it is characterized by MCV of more than 100 femtoliters. So it can be non-megaloblastic or megaloblastic. Megaloblastic has macro-ovalocyte, whereas non-megaloblastic are having round macrocytes. So the main differential is based on the bone marrow examination or based on the biochemical investigation. Causes of megaloblastic anemia are vitamin B12 and folic acid deficiency. So the causes of folic acid deficiency, main important cause is poor diet in folate deficiency, whereas in vitamin B12 deficiency, it is mainly the inadequate absorption, which is the most common cause of vitamin B12 deficiency. These are the references. Thank you.